already built. They're ready to be test run and channel.
Thank you for the question.
I
just love this screen. And we call it, yeah.
Are those sort of like, and is that part of a grant that we get and we're sort of using them through that, or is that something that's
no, it's freely available. We're posting it on NIDAMED. In fact,
okay.
we took that question from NIDAMED. We just substituted in the drugs that kids use,
Okay.
but we took their response items. I mean, if I had made this question, I would have said like once or twice to monthly. That seems like a big, like I would have wanted to put more stuff in there, but fortunately, we just stole it from NIDAMED because this happens to be the right answer.
We have gotten some pushback, actually, even from the Chan folks about just using those 3, and if they're negative, you're only asking 3 questions, and that's what you're saying. It's the.
So in our study, which it was relatively small, only a couple of hundred kids, but in our study, there was not a single individual who used a substance other than tobacco, alcohol, and marijuana, and not also tobacco, alcohol, or marijuana. So we said. I mean, if you want to ask the other questions, go ahead, but you're not going to find many cocaine users who haven't had a drink of alcohol. I mean, you just won't. I mean,
it's good to know that when we get those questions because.
Right. There's nothing wrong with asking more questions. You got a lot of time. If you have the luxury of time and you want to do that, go for it. I don't think that there's any problem.
I think it's great.
It's just looking for efficiencies, and I think you have an efficiency here. I think that the one exception where you might miss stuff is, kids who are using pain meds or using stimulants, prescription medications. However, what I will say is there's been a lot of work on this done by Carol Boyd in Michigan. You're going to miss some of those kids, but you're not missing the ones who are using it to get high. You're really missing it amongst the kids who are using pain meds because they had a headache or menstrual cramps, so inappropriate use of pain medication. And that's a lower risk group when it comes to addiction. Now, it's still something that we want to address, and you could think about if you wanted to, putting in a question about, have you, separate from the screening, you could put in additional questions. Have you ever used pain meds or stimulants that weren't prescribed to you? Because I think it's actually a different group. It's really a different question. This is really kind of screening for substance use problems and disorders. That's more like misuse. I mean, they're obviously closely related, and I think if you wanted to deliver brief advice around that, which wouldn't be a bad idea to do, you probably need to add another question.
Just before you move on, so with the algorithm and the EMR, where we're at is we do have it in test phase, and Dr. Rose did some edits. So the reason why we timed Dr. Levy to come today is we're launching this January. What we don't know yet is the ARA tool and where that falls, because it's duplicative about stuff. So we're trying to figure out how to take that adolescent risk assessment that you guys have. Some do it, some don't. And we're really just trying to take a look at, we're going to be going to you guys and seeing what do you want to do. And that's something we were going to bring up with Dr. Levy today as well. Okay. Is there a more comprehensive evidence-based adolescent risk tool that you would recommend?
Right, and I think people are working on these things. I don't think what I would do is I would take this question and I would stick it onto your tool, and you can get
That's what we are doing.
That's what I would do. But I wouldn't edit this question.
We're going to black it out. It'll be another tab that
No, you're talking about the additional question with the prescription drugs.
Is that what you're asking?
No.
Okay.
We have a 16-question adolescent risk assessment tool that's embedded. I believe. Did you offer it?
I think I did write an initial version for that. But again, I think it was Lamprey that actually was using something for it.
It's other behaviors too.
So it asked for weapons in the home, whether self-esteem, stuff like that, nutritional questions. So we have a sort of large assessment, and I think we're trying to just figure out how to, do we sort of just substitute some of the questions that were already in that with these new ones?
Yeah, that's what I would do, because these have been validated, and I would not edit that simple question. I wouldn't edit it at all, because that's how it's been tested.
No, but think of tabs. The provider has multiple tabs that they have to go through, and that's what we're trying to figure out, the usefulness without getting rid of those other questions that indicate behavior issues, risky behavior issues within an adolescent.
My only other question around the substance list, and I don't want to take a lot of your time, but I think you probably have seen this as well, is around the so-called synthetic marijuana products. We certainly are seeing younger kids and high school kids who don't do drugs, I would never do drugs, but they'll grab a bag of whatever they're calling K2 now, and they do that.
Right.
That's
So
like
I
the
think
bath
they're,
salts- The bath salts type stuff?
Spice.
yeah, the spice.
Well,
mix.
spice and that's, yeah, they're, anyway, so the question's on there, but
Right.
it's the so the way we've put it out there is you only need to ask it for kids who report tobacco, alcohol, or marijuana, because this is how, I mean, we only tested it in Boston in a certain population. It was actually a very diverse population, but, I mean, they were all living in greater Boston area. And if you think you're seeing something different here, like you've got a run of spice or something, you can put these other questions in. I mean,
Right.
What's really nice about this tool is we really only had enough users of alcohol, tobacco, and marijuana to map them onto the pyramid. But no matter what substance we looked at, it mapped perfectly. So I suspect that, for spice, it's going to map just as well. There's no reason to think otherwise, and there's no better tool out there, I can tell you that for sure.
And
So
are they-
you could collect data and you could.
Are they looking
look
at
it.
doing studies in larger populations or?
Yeah, I mean, certainly, I mean, that's always how these things work, but, NIDA has said, so I gave an interview to NIDA Notes, for those of you who are like NIDA nerds, might be getting your copy. So NIDA has put they want to put it on the NIDA Med website, they are saying green light, that's enough validation, this tool is very good, go ahead and use it.
Unitas endorsed it strongly and recommends that all pediatricians use it. That was their recommendation.
But are they they're then going out and sort of doing more, sort of larger scale?
Yes, that's what will happen next, but I think that you don't have to wait for that.
Yeah, no,
And I think that it's always going to be the case, again, we're going for efficiency and saying you can stop after these 3 questions, but obviously if you think your population is different in a certain way, or it's like a little quirky or something, add another question. I mean, I don't think, it never hurts you, it's a trade-off with time, but it never hurts you to ask another question, And, you could do a little validation trial. Well, I don't think you'll be administering them a criterion standard, but I mean, you could sort of, I mean, if you could actually publish, if you were seeing a lot of kids who were using spice and not the big 3, you'd have a little report that would be a real major contribution to the literature.
I do all the data collection for the middle and high schools in the area. They're going to smoke pot as equally as they're probably going to access spice.
Right,
So
and
you're gonna
that's
actually-
really the point, that's what we saw too, that, if you have spice users, they're smoking pot too, It's like spice is when I can't get my pot.
Yeah.
Right.
Okay, so, let's talk about brief intervention. So what does this pyramid map to? And, very simple, actually. So this is the bottom of the pyramid, the non-users, right? So they just get positive reinforcement. It's really, really, really easy. It's just giving positive feedback. Now, if you have an older kid who you think that this is a decision, who's been in a situation where they've been offered alcohol, marijuana, and have chosen not to, you might want to give them credit for the decision. You've made a good choice, because that's very self-esteem building. For younger kids, I wouldn't do that, right? Because to say to a 12-year-old, you've made some really good choices. I mean, and probably they didn't really make a choice, just never,
Right.
But what you may want to do with those kids is what we call a norms correction. So there might be, so I actually want to start by saying there's no evidence whatsoever on all the screening work that's been done. There's no evidence that asking a question makes you do the behavior, right? Just like, teaching kids about sex doesn't make them go have sex. Asking them if they drank doesn't make them go drink. Nonetheless, some people worry that if I ask a 12-year-old, how many times in the past year have you had a drink with alcohol in it? Some of them will feel like, oh, does that mean, they're expecting me to drink or to drink? Again, no evidence that this increases drinking, but if you want to build in a norms correction and say, well, that's good, because, most kids your age don't drink, if you're comfortable doing that, the NIAAA says that might not be a bad idea. So this is Julie, 16-year-old girl, no past history of substance use, and so there's her doctor. This is me, actually. So you've made a very good decision not to drink or use drugs. I hope you'll keep it up. When kids do use, they tend to get in trouble, like getting injured or even having unwanted sex. Whatever you want to say, whatever you know about the kid. That's it. 10 seconds, done, out, next. And then we take a look at brief advice. So this is for the dabblers. Okay, and so it's very similar, except that we want to actually make a very clear statement. This did not happen in the Trevor case, but we want to make a very, very clear statement. I recommend that you don't use at all. I recommend that you do not use at all. It doesn't mean that everybody's going to stop using, but we want them to walk out knowing that their doctor thinks they shouldn't use. Okay, And then, I recommend a strengths-based approach. So here's an example. This is Marcus. He's 16 years old and he injures his ankle at football practice. And he says he's used marijuana once or twice in the past year, but not at the time of his injury. And so his doctor gives him just brief advice, right? So I recommend, for the sake of your health, that you quit smoking marijuana. Okay, so very clear, direct, brief advice given as an I statement, so that it's not preaching. You come to me for health advice. I recommend that you don't drink sugar-sweetened beverages, and that you don't eat junk food, and that you don't smoke marijuana, right? But then we go on to explain why. So marijuana can affect your concentration. Over time, it can impact your mood and affect your performance, even on the football field. So whatever you want to say there. And then ending it with strengths-based if you can. You're such a good athlete. I'd really hate to see anything interrupt your future.
Can we say now that it makes you stupid? Seriously, I mean, that would be, for most of our kids would say,
If you
this,
say
this
that-
could make you lose IQ points.
Yeah,
They're
the
gonna- they're
expression is
gonna-
what you're
they're gonna-
talking about, yeah.
I
Not in that manner, obviously.
yeah, I mean, I think it's okay.
We have enough evidence to,
You would say
Yeah.
I mean, that's an association thing, not necessarily causation, but a strong association.
I think it's a strong dose-dependent association. I would feel very comfortable saying, look, all the evidence in the world is suggesting that marijuana is
I mean, you don't.
gonna make you dumb. I
Kids
would
don't
do
get to
it.
listen to that.
Yeah,
Jeez.
I think
Nobody wants to be dumb.
that's right. No, I think that's definitely relevant and salient to a lot of kids.
I don't know, I mean, he said that to us when we were that age, and we, not children, but teenagers, we would have gone, really stupid,
I think it
It
depends.
just depends on
I
age.
think it depends what age. I think it depends.
18, 20, 15.
You
Yeah.
think they wouldn't listen to that?
At a certain
Depends on
age,
how
I
you use
wonder if that expression wouldn't work, but I mean, I think there are ways to say it.
Yeah.
Of course there are ways to say
And I
it.
think it also
He's not
depends.
tested out as being.
Yeah, really?
I think it very much
Sneaky guy.
depends on your relationship with the kid.
Yeah.
So I mean, I have really all the confidence that people will be able to take these things and make them their own, right? When they're working with kids, right?
Yeah.
So, all right. So what about the monthly users? Okay, remember that this is the tricky orange group because it's a small percentage. It's like 10% probably of 12 to 17-year-olds coming in. Maybe a little more if you're looking at 14 to 17-year-olds, 18-year-olds. And these kids need like what we call a brief motivational intervention. So, and just to be really clear, like you do not need to go off to a motivational interviewing retreat and take 3 years off of your career to study motivational interviewing to do these. They're very loosely based on motivational interviewing, but they're really pretty structured. And just a couple of steps, right? The first thing you want to do with this group is you need to know a little more because you want to ask about their use patterns and you really you want to start scoping for problems, and you're going to find them in this group because this group has the mild to moderate substance use disorders. And when you do find the problems or the ambivalence, you want to use that as a pivot point in the conversation. I'll show you an example of what I mean. As with everybody, clear medical advice to stop. They should not leave your room without hearing clear medical advice not to do it. Okay? What they do is their decision, but your advice is that they don't do it. And then you got to connect the dots for teens. So, often we can get them to a point where they go, oh yeah, okay, well, I don't want to stop, but I guess, I've been drinking too much, I'll cut down a little. Great. Now you've got them just in the spot you want them, but you've got to connect the dots. So how will that happen? What will that look like, right? And you want to make a plan with them. And it's really, you could do it pretty quickly. I would say if you get them to that point, you do want to ask permission to bring parents into the room, because a lot of them will give it, and I think that's helpful. And then, invite them for follow-up. It's so hard to get teens to come back, particularly if parents aren't involved. So make a note in the chart, and if they won't come back, just to see you for this, they will come back for something else. Make sure that you follow up the next time. It's like a first thing in the chart, right? It's like a high-risk drinker, where are we at? So these are some questions that I like to use. I've been doing this for 14 years now. I've seen literally thousands of kids. Yeah.
So just out of curiosity, as far as that sort of flagging in the chart, making it obvious when they come back in. Again, in the era of sort of electronic medical records, how exactly do you sort of see doing that without sort of making it something that whenever their chart is requested for some other purpose, that it is
Right.
it's
So
sort of right there in the front that goes out?
So what I gotta tell you is that I hope you're thinking about how to keep some information confidential for teens and
Yes,
put this
yeah.
in that pile, right?
Yeah.
Just, what do you do when they ask for birth control? What do you do when they, there are certain things that just, you gotta hold confidential, and hopefully your EMR, I know our EMR doesn't actually allow access. Once a kid turns 13, parents no longer have access to their EMR. So, they, through the portal. I mean, parents can still request their chart, but then it's like a formal procedure. The confidential notes aren't sent. And if a parent ever said to me, I really want to see your notes, Dr. Levy, I want to know who's giving my kid marijuana, I would sit the parent down. I mean, because, I think you can prevent accidents with some smart policies, but the non-accidental one, the aggressive parent, I would sit the parent down and say, at least in Massachusetts, and I'm not sure in New Hampshire, but, it's your right to see this chart, but really please realize that if you insist on seeing the chart, your kid will probably never speak to me again, and that means you're going to need to find a new provider or not have somebody, who can be effective working with him. So the decision is yours, but please consider the consequences. So, that's...
But just as far as, again, if children are coming in for sort of some confidential type topics, plus, you're probably not going to put it somewhere like on their problem list, which would be part of something that would go out for everything. Is that a fair assessment that on their problem list, you put sort of substance use or marijuana use, or do you?
We do, and you can talk to our EMR people about how we manage that, but it's kind of, so any provider in our system can actually go on and see it, but nobody else can. So, and I think you have to make some decisions. There are real advantages to having everybody in the system be able to see it. Yeah.
I guess my concern is just that with some visits, the problem list gets included, whether or not that was addressed at that visit. So if they came in for an asthma visit and somebody asked for that, no. If it's on their problem list, that could then show up.
Well,
And who would get it? Because I would want a kid, if a kid's smoking marijuana and coming in for asthma, like I would want
alcohol,
whatever it is, right? I would want that, I would want that to come up unless it's getting into the hands of parents somehow.
Yeah, and then
That's the
Well,
tricky,
the
that's
chart
the tricky
summary
part.
just goes off with problem list, so anytime the clinical
Right.
summary is printed.
That's what we're
I
trying
see.
to work on.
So the way we
And I
do
just
it
wasn't
is that
sure
we
if
do
you had
not,
some way that you have that.
13 and over, those summaries don't go to parents. They don't go, the parents don't have access to the portal.
Yeah.
And if it's printed, we only, we ask the kid, do you want this? Or do you want to just not take it?
I was assuming that it would not go into problem list unless there was actually diagnosis, and that those terms in the flow sheet don't have to go in there, just like for the ARA, they don't have to. So,
I think as long as they go somewhere to signal you. But most of these kids, and I don't know if you're going to be doing diagnostic interviews, the monthly or more users, most of them will have a DSM-5 diagnosis. So,
Well, our intervention, we actually have the craft, and the intervention will be referred to internal BHP if they're, if they are scoring in that range where they need, like they have a DSM-5 pop up, and so they're kind of tools for the provider to either make that diagnosis or refer to us for that.
All right. So getting back to, these are assessment questions that I think are really helpful, that, just come from my experience doing it, just tell me about it, right? So like, when did you start, and how often do you drink, how much do you drink, how often do you smoke? A couple of questions I find really helpful. Have you ever regretted anything you've done because of alcohol or drug use? You wouldn't believe how often that question is asked with these more regular users. And actually you have to be a little ready, because I've had kids just kind of crumble in front of me, reliving sort of stories. So just be prepared a little bit. And have you ever tried to quit? Because anybody who's tried to quit has some reason for quitting, and so you want to know about what that is, because that should be motivating, right?
Almost a cage question.
Right, well, so, similar to the craft questions, the craft also, is a very good tool to use as an assessment guide. So the way I would recommend using the craft is, they're really written as closed-ended questions, but they're so clinically juicy that, it's a shame to waste them as closed-ended questions. I think what you want to do is, and because we know S2BI maps so well, you don't actually need to score it and say, oh, is it a 0 or whatever, too. It becomes irrelevant. What you want to use the craft for is to find, points of ambivalence, right? You know, and it's the same kinds of like, have you ever gotten into trouble, or, you know, or is your mom on your, you know, friends and family, like, if a kid says, yeah, my family is, you know, my family it says I should cut down, well, tell me about that, who, you know, oh yeah, my mom's on my case all the time, you know, that's the kind of like clinical conversation you want to be having, and I think you can actually have it very quickly and efficiently by using these questions or this tool in this way.
Has this been valid? I've never seen
The
it.
craft.
The craft,
Yeah,
I
that's
think
the
it's
one
in
that-
your,
Yep.
it's been validated as a screen,
Yep.
but again, I think it's actually misplaced as a
Yeah.
screen. So, you know, it has screen-like properties that actually work well. You know, if you answer 2 or more of these questions, yes, you probably have a substance use disorder. But, you know, I would say that if you're going to use the S2BI model, you don't need the screen properties. What you actually need is, you know, just questions that are going to start the conversation, and that's where I think the craft could be really
And
helpful.
based on your work, what we did was we put that craft in for monthly to pop up as just
A secondary.
Good, good. Sounds good.
So here's Katie, she's a 17-year-old girl who comes for physical, and she says monthly alcohol use and once or twice to marijuana use. And so here's the evaluation. So you talked to her a little. Started drinking at parties as a freshman. By the way, that's very typical. Around 14, there's a big bump in initiation. Now she drinks about twice a month, 4 to 6 shots, and that's enough to get drunk. And she answers yes to forget. You ask her about it, and she says, well, she's forgotten things that have happened on a couple occasions. She's had a couple of blackouts. And then you ask her about trouble, and she says in the fall, she was suspended for 2 weeks because she was drunk at the homecoming game, and she threw up in the bathroom. And then 3 weeks ago, she had a blackout while drinking. She thinks her ex-boyfriend may have had sex with her. And, you know, this sounds like a very extreme case. I put a couple of things on it, but I hear this all the time, from kids who you could go, oh, B+ student, you know, participating in athletic, you know, drinks socially. You know, these kids have stories, you know. And so that's the story that you want to get out. And so here, the doc is, here's the pivot that I'm talking about. So the doctor says to her, you know, the blackouts sound really upsetting. I'm concerned because kids often get into trouble when they drink, right? So it's like, you know, your story is so common, actually. You know, just like what happened to you. How do you think you could protect yourself in the future? So now the question is, you know, something bad happened to you. How can you protect yourself so this doesn't happen again? So Katie does what every self-respecting 16-year-old does. She says, well, I don't have a problem and I'm not going to quit. That's usually what comes out first. But if you give her a minute to talk, she'll also say, you know, and you could say, okay, you know, I hear you. But what about those blackouts, right? And she says she does want to quit down. She does want to cut down. She wants to be smarter about her drinking. Like, you know, so those kinds of questions prompt that kind of response. Yeah, I don't want to quit, but I don't want that to happen to me again, okay? And then here's where you do a couple of things. First of all, you give advice, because she's going to walk out. She's not quitting. She's going to walk out with some sort of negotiated plan to cut down. You want to make sure that you're not really endorsing that plan. You still think she should quit, right? So you deliver that advice. Only you can decide whether to drink or not, but as your physician, I recommend that you don't. But if you're not willing to quit, okay, I think cutting down is a good idea. Now, you've delivered that, and now here's the kind of the bridge. How can you do that, right? Because if you stop before that last sentence, she's going to walk out and say, okay, I'll cut down. With adolescents, we have to connect the dots for them. Tell me exactly what you mean by that. If you don't deliver that, nothing will change, I can promise. So come up with a plan, write it down. In Massachusetts, we've developed these little worksheets for doctors to use, right? I mean, they're very simple. You just, you know, okay, she's using alcohol monthly. And it says on the top, my doctor recommends that I quit. Right now, I have decided that I am going to, and then they fill it in, you know. And so here's what Katie does. All right, I'll cut down to 2 or 3 drinks. You know, I mean, at some level, it's like, yeah, okay, big deal. You got her from 4 to 5 to 2 to 3. Is that a big deal? Well, it is a big deal if we're stopping her from having those blackouts, right? And that, you know, she's not having date rates. So your mind turned never to drive or ride with an impaired driver. She said no to that question anyway. You ask her not to have sex when she's intoxicated, like you bring this up again, and she says, yeah. And then, you know, she's not going to come back for this, but you make a note, and so next time she comes in, you're going to follow up. Okay. And then how about the kids who need referral to treatment? So these are your monthly or mores. Okay, most of them are going to be marijuana or marijuana and spice users of some sort. These are kids who, you know, if you can get them to reduce while you're having them in the office, that's great. You also want to hook them, you want them to see Sandy, frankly. So here's the intervention. Same steps, except that, you know, when we're talking about planning, we want to get them to the right level of care, and we want to include the parents to assist with treatment compliance, and then, of course, we want to follow them up. So here's Alex. He's a 15-year-old boy who presents for a school physical, and he's a weekly marijuana user. Well, he checks weekly. He's actually, most of the kids who check weekly will be daily marijuana users. We don't really know just from the box, but he is in that high-risk category. So you interview him, and he says he started smoking 6 months ago. He's only 15 now, right? Now he smokes every day, and he says he has to relax. He uses marijuana when he feels stressed. He often smokes alone. This is very typical. His mom's caught him a couple of times, and now she's constantly on his case, which he finds annoying. He thinks she's overreacting because we all know marijuana is not that bad. And he was brought home by the police, who caught him smoking in the woods, but they didn't file any charges, so he doesn't think it's a big deal. And then you ask him, and you're like, well, how's school going this year, by the way? Because that's one of the first things we see is the grades drop off. And he says, yeah, well, my grades have fallen, but that's just because I just started high school and it's a little bit harder than middle school was, and marijuana has nothing to do with it. So he's really like, he's not getting anything right now, right? And so, the doctor's gonna try and follow up a little bit. So she says, well, it sounds like you really do have a lot going on, and you're starting to rely on marijuana. I hear you telling me that, you know, you're using it to manage stress. I wonder, why do you think your mom is so concerned? And this is a question that I use a lot because kids, you know, kids in adolescence, they have to reject everything their parents say. And at the same time, they're internalizing it. It's right, it's like the great dichotomy. It's like the great irony. So on the face of it, they're like, yeah, my mom's crazy. She overreacts. You know, she doesn't get it. She's just old-fashioned. And at the same time, they're hearing these messages, right? And so, you know, I get kids to say this all the time. You know, try it. I guarantee you'll get kids to say it. He says, well, my mom says marijuana is bad for my brain, and she thinks my grades are dropping because of smoking. And actually, I think that in most kids, this is a projection onto mom of what Alex, you know, really believes about marijuana. And then he says, and then again, he gets defensive. He says, well, my grades have dropped for lots of reasons. You know, high school's harder. My teachers don't like me. He goes on and can think of 10 reasons why his grades will drop. So she agrees with him, and she says, yeah, it sounds like there are a lot of reasons for your grades to drop. You know, I get that. It's probably not all due to marijuana. You know, at the same time, it's also true that kids who smoke marijuana tend to do worse in school. And, you know, I agree with you, and you know, it sounds like you and your mom have actually noticed that, and I agree with you. And as your doctor, I recommend that you quit. You know, marijuana is bad for your brain. And by the way, chances are, if you decide to quit, you know, things at school will get better, things with your mom will get better too. So you're delivering that message. And Alex says, look, you know what, I think this is stupid. Marijuana is herbal, it's all natural, I don't want to. And by the way, I can't even imagine how I would manage stress without it. It's like the only thing that really relieves my stress, right? So she acknowledges and she says, yeah, stress management is really difficult. And she asks him, like, you know, since this is really an issue, I wonder if you'd be willing to see a counselor who can help you with stress and also discuss marijuana. Okay, so right, it's like the express train to behavioral health, right? I mean, we're just trying to get them to accept a referral to behavioral health, and then, you know, the other half of the team will just pick this up right where they left it off. But, you know, often the kids who don't want to stop smoking marijuana, who won't go to talk about marijuana, but they will consider going to talk about stress, right? So he's reluctant, but he agrees. And so his PCP says, I'm really glad. I think that's a really good decision. I mean, you've got really nothing to lose. It's just an appointment. And then she asks permission to talk to his mom, and because she knows that without that, you know, he's probably not going to go. And she says, look, you know, your mom's on your case all the time. Don't you think she'd be pleased if we tell her that you're agreeing to go for an appointment to discuss it? And Alex says, yeah, I guess. And so he agrees. And that's it, right? I mean, that's your intervention. I mean, it's a little conversation. It doesn't take long. I've been doing this long enough to say that, like, everybody comes in as different, but there are a couple of themes that come up again and again and again. And when you start doing this, you'll realize, oh yeah, I've kind of heard something like that before. Let me see if I can get this kid, to move along the way this one did. And I would say that once you really start this, to come sit around this table and to talk about the kids and, how it went, how the brief intervention went, and whether they got referred and where they are, it'd be a really great exercise, and everybody will get much better at managing all of this.
You have mental health, you have team meetings, right?
Every week we do 2 hours, and we review all of our new cases, plus anybody who we're stuck with. And that's like a critical part of our team practice, because like you, we are multidisciplinary teams. All right, so this is now talking about, so we used to actually stop the talk there and just pretty much say, okay, that's referral to treatment. And here that might largely be true, but I wanted to spend just a couple more minutes because, in most places in the world, like we would say, okay, so you refer this kid to treatment, and for a lot of people that means handing a little slip of paper with some phone number on it that the kid's never going to call, right? And that's actually not what we want to do, right? So here are the steps for referral to treatment. Okay, so like once you've got a kid, he's gonna, that you want him to go talk to somebody, but what are the steps? Well, first I've got to convince the kid. That's kind of what we did in the last vignette. Then I want to get permission to include the parent, because I know if I don't include the parent, what are the chances that the kid will go on his own? And then I've got to convince the parent of the need, right, which the parent may or may not be aware of. I've got to determine the level of care. This is a really important point. For the vast majority of kids you see presenting for primary care, the level of care is just going to be outpatient, right, either like individual or group counseling. And I have to find community resources. You're really lucky here. I don't think that's an issue, but in the community, and maybe like if the behavioral health team wants to refer on, they've got to consider the patient's insurance and bed availability and convince insurance companies that the kid meets the level of care, and that all has to happen before the adolescent changes his mind. So this is a real tango. So we talked about convincing the kid of the need for treatment, right? And it doesn't have to be treatment for the substance use. If this kid is drinking because he's depressed, well then let's talk about the depression. Okay, so whatever it is that's going to get him to come back. It's always good to get the permission to include the parent and convince the parent of need. I think that once you've got the parent in the room, you're really in the sweet spot. I mean, I think, usually that part will be one of the easier steps. But then you've got to determine the level of care, right? And, so you've got to consider, right? So it's almost always going to be outpatient, but you want to consider co-occurring mental disorders, right? I mean, if the kid really has major depression, maybe he should be seeing a psychiatrist, who could do some of this work. Of course, there's issues of parent and patient preference. There's always problems with insurance coverage and program availability. What have I got? Who can I refer to? Just as a reminder, we always want kids to go to the least restrictive setting. It's almost always going to be outpatient, except in a few specialized cases. And we always want kids to go to specialty programs for adolescents when we don't want them mixed with older patients with more serious problems. So what's available? Well, you've got your outpatient, you've got individual or group therapy, you've got family therapy. There's also intensive outpatient program. That's like kind of a combination of all of them, but for a couple hours a day, a couple times a week, or partial hospital or day program, and that's like 9 to 3, 5 days a week for a couple of weeks, right? And so that's what's generally available. I don't know what you have locally, but just to say, there are a couple of evidence-based therapies that can be used in individual counseling, motivational interviewing, like real motivational interviewing, by somebody who's been trained and has done the 3-year course. Cognitive behavioral therapy helps at a certain point in treatment, and contingency management that you guys were talking about. They're all established as evidence-based therapies. So getting to a trained counselor who can do that stuff should work. Do you guys have group programs available to you?
Not yet.
Okay. So, there are pros and cons, right? So, they're certainly cost effective. They allow for peer support, and they're definitely a developmental preference for many teens, so those are the pros. On the other side, they're really not that well studied. Availability is an issue. But this is a really big one, so if you're thinking about doing groups here, I really encourage you to think about contagion. So if you're mixing kids, the kids who really are pretty convinced at this point that they want to stop with the kids who are there because somebody said they had to be there, what you get is a group where you've got a couple of kids really talking about how wonderful it is to smoke marijuana, and that can really interfere with some of the other kids. So you want to be really careful that you get kids kind of at the same place in the groups. And by the way, we just published some early results from our manualized group therapy program in children's, and that's available in substance abuse in the September issue under the name Pugetch. Yeah, that was nice.
I'm sorry, what is that about?
It came out in September. Look at substance abuse is the name of the journal, and Pugetch is the first author. And if you can't remember Pugetch, if you search on the Levy, it should come up. So family therapy is one of the best validated, effective treatments for treating substance use. So you work with the kids and the parents, and you work on all of these things. Is family therapy an option? I mean, they're pretty intensive and they're expensive. In Boston, we can get it for certain kinds of insurance, but I don't know if it's available here.
We're really looking into that this year, we're doing the feasibility kind of thing.
Right.
Not for teens so much, but like for adults.
Okay. So I don't know to what extent. Here's something that I want to say. Is anybody here? No, there are no. Okay.
We're working on it.
Yeah. So I think so. Amy and I decided that you guys need a training course here.
Not you, New Hampshire.
No, New Hampshire in the state, right? Because
We would not be including under 17 though, if we were to consider an NET objective.
It'll make your argument, Sharon.
yeah. So I mean, why not?
Because we don't have pediatrics and.
Yeah, but
they're
these guys
private,
treat
yeah.
kids.
And it comes with a whole different set of issues. That we have one land act that can see adolescents, and Sue's the only one, Dr. Rose. So we need somebody we need social work integrated. We don't have a real strong specialty on adolescents.
So here's my argument. So medication-assisted treatment, it really works. It's a shame not to give it to the younger kids, right? I mean, in some ways, they've got the biggest future ahead of them, and they're earliest in their career, and I think that's where you could make the biggest difference. If you can't get groups and even individual running for these kids, I would give them medicine and have the prescribers do a little bit of counseling, because it looks like it works and there's really not that much else, right? Do you have methadone programs that'll take teens?
No, 18. There's no adolescent
Right.
treatment in this
So-
area, and so in our pay structure is really challenging in New Hampshire. So there are a lot of things that we have to look at.
All right.
And
So, I mean, obviously, I'm overstepping my boundaries here. I will just say, even if you just give the medicine and you bill it as a medical visit, just the way you would for a kid with ADHD, who you're gonna prescribe, Adderall to or something.
But are you talking more about the Suboxone?
Yeah.
So they have to be approved and licensed under
It's
that.
an 8-hour waiver course.
Right.
Yeah,
It's
so
easy.
hour class, that's right.
It's really easy. You could do it 8 hours online, but Amy and I said we gotta get one in New Hampshire, so you do 4 hours
Is
of
it different than for adults?
No.
Well, it's the same thing actually, but
License.
it's the same thing, but we did create a course for people who are interested in treating, it's the same material, but it's covered with pediatric examples, and we take you through 30 cases of little tiny, vignettes of kids and, what you can do. And, I think that if you don't have all the bells and whistles, don't let that stop you from doing something, it's don't let the perfect be the enemy of the good, or whatever they say, I mean, if you can just get some buprenorphine on board, maybe you'll get some kids to stop. I mean, if you've got providers who really care about, they'll do a little bit of counseling. It's not going to be perfect, but it seems to me like it's better than nothing. This is a sample buprenorphine contract. If you take the course, you'll see it. It's just a study that was done by Woody and published in 2008 in JAMA. And really what he did was he took 15 to 21-year-olds and he gave them either buprenorphine or I think they got clonidine in the control group. And he did this just for 12, he gave them buprenorphine. They either got 2 weeks and came off the medication, or 12 weeks and they came off. And those were the two groups. And he compared them, and the 12-week treatment group had fewer opioid-positive drug tests at 4 and 8 weeks. And then he started to taper at 8 weeks, and by 12 weeks, the two looked the same. So it's like the medication was working.
12 weeks is all that it was studied, or 12 weeks was actually all that was prescribed?
This is really interesting
So
because
generally a 30-month
No, that's right, but the study only went out to 12 weeks, and they tapered kids off from 8 to 12 weeks.
Quickly.
Because that's how, because, I'll tell you that, I wrote one of the first papers on this. I published the case series in about 2006, 2007, before this study was done. And we reported on our first 3 kids who we treated with buprenorphine. We started in about 2003. And I could not get the thing published because the reviews kept coming back saying, how dare you put adolescents on Suboxone for that long period of time? And, finally I said to the editor, have you read the cases? One of the boys overdosed in the field and was in the intensive care unit 3 times before we started him on buprenorphine. It's like, what choice do we have for a kid like that? I mean, there's like no doubt in my mind that this kid, which one, we're going to wait for a fatal one, right? So the editor accepted my comments. It was a little case series ultimately published. This is all the data we have, this is all we have to go on, but I can tell you, the spontaneous remission rates are extremely low for this problem. So if you just leave them out there and do what they're going to do, they're going to keep using. And then they'll come back when they're 18 maybe, and they can, but that's a shame. That's really a shame. So, I think that you've got to think about bridging. So this is my visual. So, I'm having trouble with the pointer again. So, this is brief intervention. This is 5 minutes as part of your physical exam. And this is like a 90-day rehab program, but almost all of the kids who need something in here, right? So where is it? You're going to have to think of ways of bridging that. This is what I think my research assistant spent far too much time getting the text lined up just like that. But at any rate, this is what we're thinking about in Boston. This is why we built the adolescent substance use program, because we treat all of the kids in here, okay? The kids who are opioid dependent need buprenorphine, the kids who are smoking marijuana a couple times a week, the kids, all of them who are falling in here, we're trying to pick up. And, I think really that's the charge for the mental health team. And then, I don't need to go through these because they may not even be available here. Do you guys have recovery high schools?
No.
Okay. And then, acute residential treatment, do you have that? Detox.
On the other side of the state.
On the other side of the state. Well, it's like a detox. So then even more pressure on you to do this outpatient, but basically, this is really good for kids who are kind of in crisis, who've got mental health and substance use disorders who really need stabilization. Most kids can be treated outpatient, but the kids who come in who are suicidal, who are manic, who are this or that, they might need that. And then, of course, residential treatment is like when almost fail, when kids are homeless or have like terrible environmental and other SES problems, then I think you can think about residential programs, but it's really like a last-ditch effort, and most of them you just want to treat and send home. And of course, therapeutic boarding schools, these tend to be very limited. So you got to find the community resources that take the insurance and have the bed, and convince the insurance company that the adolescent needs the level of care that you're asking for, all challenging. So if you're gonna send a kid outside, I'm a strong proponent of assisting parents in making the call to determine admission procedures and bed availability. Don't just send the parent with a phone number, because these can be completely frustrating. And then if you can, provide a level of support, explaining the rationale for the level of care that you're asking for. Because otherwise what tends to happen is, okay, the kid says, okay, I'll go, and the parent finds a bed, and then they have to get like an insurance clearance through the emergency room. So they go to an emergency room where they're seen by an ED doc who knows really very little about addictions, perhaps nothing at all, who says, well, I don't think that this kid needs level of care because this kid isn't suicidal. That's not how you make level of care decisions for substance abuse treatment, right? So what you want to do is send a letter saying, this kid is shooting heroin IV and has no access to treatment, whatever the reasons are. Make sure it goes in a letter and that the kid or the parent hands it to the evaluating doctor so that they really understand what the issues are. And then, of course, often you'll get, okay, well, yeah, you meet level of care, but there's a 2-week wait, and so, you really got to stay connected with these kids, right? It's really helpful if you can decide, help the school decide if the child can attend school safely. Some of them can, some probably shouldn't. You might want them to be referred to primary care or other parts of the treatment team while they're waiting for placement, right? So, you might do an HIV test and hepatitis, like in primary care, you might test for STD. There are things that you can do while you're waiting, and having them come back is always good. And if you're giving them Suboxone, I'll tell you they'll come back. So, gotta reassess. So they go to treatment, they're there for 3 weeks. I'll tell you, they are not cured. That's, you're just hoping that they're stable, that they can go back home, they can go back to school. Primary care, you gotta help determine when the kid can re-enter school. For some kids, they shouldn't go back to school because they're triggered and they have a dealer and this and that, and there really are no options. Consider like home tutoring, do something so that the kid doesn't go through the revolving door, right? And then if they do go back to school, you want to help monitor them. So you want to see them frequently because, chances are nobody else will.
The risk is highest before going into treatment and coming out of treatment, so oftentimes the kids will up what they use and are at risk for overdose. Do you see a lot of that?
Right before?
Well,
Before they go
sometimes
to, like, a
when they know, like, I'm
residential?
going
Yeah.
tomorrow, so I just want to use
Yeah.
one last time, and so they might, that's true. And so, staying really connected, talking to parents about monitoring their kids, making verbal contracts not to use. Do you think you cannot use, do you need to be admitted to a hospital bed? Because, if you can't not use, maybe that's what we need to do here. Talk to parents about monitoring, have a 911 plan, mental health status changes, right? If, bring them into the emergency room, have them reevaluated if they become suicidal, if they're, taking something like have a very low threshold for coming back in. That waiting period is a very, very high risk period, I agree. This is just a little, it's complicated, but it's a little algorithm that this is what I use to try and
Try to do this.
decide where kids go, and you're welcome to it, and you might want to revise it a little bit, because it depends on, if there's going to be withdrawal, right, or not, and whether they're willing to go get treatment or not. And, if they are, it's a relatively easier thing, but if they're not, you have to decide, well, is this really life-threatening? And if it's not, what are my options? And so you can have this as a reference. Okay, so one more vignette. So this is Jane. She's a healthy 18-year-old girl who presents for college physical, and she reports drinking once or twice in the past year. And her doctor assesses her as once or twice and gives her brief advice and says, I recommend that you avoid alcohol, particularly as you're heading off to college. Lots of kids drink too much and get into trouble. And now that you have your driver's license, I want to remind you of the dangers of driving or riding with somebody, driving after drinking or riding with somebody who's been drinking or using other drugs. Please never ride with an impaired driver. Always make sure you have a plan B for getting home. Okay, so when they hit 16, 17, like that has to be missing. So 3 days later, Jane attends an end of the summer party with some of her high school friends. And guess what? Her boyfriend, Trevor, is there. And he drove her to the party, and he's been drinking the entire party. She's seen him drinking heavily. So, she remembers that little talk she had in the primary care office, and she calls her parents and asks for a ride home. Trevor's really angry. He storms off, gets in the car, and leaves without her. And 4 years later, Jane graduates college with honors, and her parents are very proud.
A nice ending.
And I just want to
Quick
acknowledge.
question, we were talking about sort of the other, as far as getting somebody into treatment, and you were talking about sort of plans for sort of 911 calls and things like that. I had seen an article recently, and it actually wasn't related to this, but actually it was related to prescribing opiates and having emergency naloxone available. Is that something that, do you ever do that? And
Oh, yeah.
so how do you prescribe that?
You could actually, so in Massachusetts, it's really easy. You could buy it over the counter in Walgreens, I believe. But we give them all a prescription. We have,
And is it oral or is it?
It's
like-
intramuscular,
it's-
or you can do nasal.
there's a nasal version that the parents are trained to use. And we have actually, so all parents whose kids are using opioids should be trained to use naloxone.
That's
Life-saving,
not-
life-saving.
That's
Narcan.
not the case in our state.
No,
So
right.
don't,
Okay.
We're actually going to push out primary care physicians to be prescribers. You can prescribe now. It's not illegal for you to prescribe that. What is technically still illegal is giving it to caregivers for the adolescent or the young adult who is at risk of overdosing. Because the
That's
prescription has to be,
illegal or
it's
legal?
illegal because it has to be to the prescribed, it has to be prescribed
To the kid.
to the person that's going to be the recipient of that medicine. And so
Is that just
we
because they're
can't,
minors? Because.
no, it's across the board, that's a DEA.
Well, that's, yeah, you always have to prescribe
Right,
medication
like
to
an
a person who's gonna be
like an
receiving
EpiPen.
it, yeah.
Right.
So you don't write a prescription for the mom for the kid.
Right.
That wouldn't make sense.
Right, but in the case of Massachusetts, it's over the counter now, we're studying that right now. I think
Yeah,
we're gonna have
New
that.
Hampshire's
track.
doing that. I wouldn't be surprised if that changes
I-
next legislative
Yeah.
session.
And actually, if you want to convince yourself of the efficacy, look for an article by Alex Wally, Walley. He looked at 2 towns, okay, that were adjacent to one another in Massachusetts. One of them they established like a Narcan program where they taught parents and, relatives how to do this. The other one they didn't. And they saw the opioid deaths plummet in this one county with